Press the record button, so we should be recording now. So, request when we aren't sharing slides, if everyone could be have their screens on gallery view so we can see each other, because part of Project ECHO is to be a community, and we want to know who we're talking with. So is Ria Markowitz, and I'm from the Georgia Cancer Center and part of the hub team for teledermatology in rural Georgia. Dr. Doug Patton and I will be serving as co-facilitators of our session today. So it looks like we have about 17 or 18 participants, and I think we have, let's see, 3, 4, 5 or 6 of our healthcare providers from our clinics. And we have someone else who just came in, one of our providers. And we have 2 MCG students with us. So will the students wave? And so we can see you, students. Are they there? And will everyone please put their video on so so we can see each other. Again, that's part of Project ECHO. And will the healthcare providers please wave so we know who you are? Okay, that's great. And we also have members of our TeleDerm team members. And then our dermatology staff. For people. Okay. So that we can further get to know each other, can you indicate right in the chat your full name, the clinic you're from for the healthcare providers, or whatever your affiliation is, and also your email. And Kenza will have a model of that in the chat, probably already. So let's review today's agenda. If I can have the next slide. Next slide. Okay, so here we are. We're going to start with an introduction for about 10 minutes. We've already done some of that. We'll have our didactic presentation by Dr. Rabinovitz on fundamentals of dermoscopy terminology. And then we will have 2 case presentations by Dr. Jabo, and we'll have a brief discussion after the first one, and then a little bit longer discussion after the second one. And then we'll have our usual wrap up and announcements. So I'd like to make some introductions first. I want to point out Claudia Guillen, whom you all know. This is Claudia's last TeleECHO session with us. She's already left Augusta and is zooming in from her home in Mexico. She's going to, as you know, she's leaving dermatology to begin a medical residency up in Chicago. And I really want to thank Claudia for all her efforts that she's put into teledermatology in the last 6 months. So thank you, Claudia. Let's see, I'd like to acknowledge our derm team members. So Dr. Greer, who I don't think is on today, he'll be leaving us this summer. Dr. Kendall Buchanan from AU's Care Center for Dermatology in Aiken. Kendall, wave. And we have Dr. Etsu Jabo, who's a 3rd-year resident in the derm department. She's over here in our hub. And we have Dr. Loretta Davis, the chair of dermatology. We also, and we have Dr. Rabinovitz, of course, who will be presenting our didactic session today. And then here at the hub, we've got Dr. Kenza Mamuni and Dr. Marisol Miranda. They're managing all the controls. Marisol is acting as our interim program manager for TeleDerm until our new program manager is hired. Kenza will be sharing the CME link with you in the chat at the end of the presentation. So now I'm going to introduce my co-host, Dr. Doug Patton, who will take over. Dr. Patton is the Dean of the MCG Southwest Regional Campus, and he spent most of his professional career as a rural physician. So Doug, take it away.
Thank you, Rhea Beth, and thank you everyone who's part of the team and also part of the participant crowd out here. Our crowd is growing and grateful that we've been able to add some medical students to the list of participants today. As always, we'll start with just a couple of announcements and reminders about what we do here at ECHO, and ECHO stands for Extension for Community Healthcare Outcomes. And sort of the tagline for this is moving knowledge instead of people. In other words, bringing expertise to providers in areas where they may not have access to certain specialty services, but also relying on the provider experience shared amongst each other to enhance the ability to provide care where you are. Next slide, please. So the sessions are designed for educational purposes and quality improvement purposes. And because of that, all of these sessions will be recorded, they'll be archived and accessible for review later on, and also for the opportunity for them to be shared with others who are not even necessarily part of the sessions. By participating in the sessions, then you're consenting to being recorded. You all saw the buttons and things when we had to click into it when we got here. But because this is for education and QI and PI purposes, it's important that we not mention PHI in our discussions. And towards the end, you'll start seeing information in the chat relative to how to obtain your CME and CNE for your participation. And of course, you can always email questions at teledermatology at augusta.edu. And of course, we'll be monitoring the chat along the way as well. So please feel free to do that. Next slide, please. Because we collect this data on participation, we use your registration information, things like that to be able to track participation and things. The chats, the comments, recorded presentations are all there, but it will be kept confidential. It may be used for reports and things like that in the future, evaluation and research on how to improve even the ECHO performance itself, how to make it better. Just a little disclosure there. Next slide, please. Or that may be, oh yeah, these are just the general Zoom reminders. Mute your microphone when you're not speaking, unmute when you do speak. And you can type questions into the chat session. You can raise your electronic hand, which is down. If you move your cursor down to the bottom of your screen, the buttons will pop up and you can see a reactions button. If you hover over that, you'll see the ability to not only raise your hand, but to applaud, thumbs up, and smile and other things. When you do speak, remind us of who you are by providing your name and your clinic location. And let's keep the cameras on this time. I know we have a tendency to want to fade back. We do understand that some people have broadband challenges where you're participating from, and if that creates access issues for you, we will understand if you can't. But if you can, please leave your cameras on so we can see everyone during the presentation. Of course, the gallery view allows for optimal viewing of the most faces possible during a meeting. And again, you can put notices about technical challenges into the chat, or you can email Kenza at kmamuni@augusta.edu or Marisol at mgalvis@augusta.edu. I think that's all of the technical issues and reminders that I need. So I think we can stop screen sharing at this point until we get ready for Dr. Rabinowitz's thing, but it's my pleasure now to introduce Dr. Harold Rabinowitz, our featured speaker again today. For those of you who were able to participate before, you know he can move through some information at lightning speed, but not so fast that that rain has plenty of chance to soak in. And we do appreciate his presentation style and the wealth of experience he brings with us. He's part of the Augusta University dermatology team, but he also maintains private practice down in Southern Florida. Today, we're going to expand on our previous conversation by talking more in depth about the terminology as part of the fundamentals of dermoscopy presentation. This presentation will be about 20 minutes, and then we'll have a few minutes for some questions after that. But of course, you can always type your questions into the chat during his presentation. We'll review those at the end, and then we'll also open up for that. But with that, I'm going to turn it over to Dr. Rabinowitz, and you can now share your screen. Thank you so much for joining us again, Dr. Rabinowitz.
Thank you. It's a pleasure to be with you. Do you see my screen? Is it on?
Fine.
Yes.
Oh, great. Okay. So today we're going to talk about the language of dermoscopy. And you're going to hear a lot of terms: radial streaming, streaks, dots, globules, pigmented network, shiny white structures, clods or round structures. And a variety of terms have been coined to describe these features since its inception back in the 50s. And two different types of terminology have emerged: the metaphoric, which is the way I was trained, and the descriptive. And back in 2015, the International Society of Dermoscopy had their consensus conference to standardize terms. And these are the terms that are now currently used. And we're going to go through these. The first are lines. And when we see lines, it refers to the metaphoric, a pigmented network. The descriptive are reticular lines. And a pigmented network is a grid-like pattern consisting of interconnecting pigmented lines surrounding hypopigmented holes, and it's seen in melanocytic lesions. The lines correspond to the melanin in the melanocytes or keratinocytes in the epidermal reedy ridges, and the holes correspond to the dermal papilla. So when we have this type of pattern, where we see a typical network pattern, which is characterized by these lines and holes, it corresponds histologically to the melanocytes, which are at the base of the epidermis. Here we have examples of nevi showing you this type of pattern. It's known as a typical pattern. The pigmented network typically is symmetric, uniform, with little variation in color and line spacing. And this is a typical network. In contrast, an atypical network is asymmetric, non-uniform, darker or broadened lines with heterogeneous holes. And this is an atypical pattern. When we see a typical pattern, it's characteristic of a nevus. An atypical pattern is often associated with melanoma. Typical and atypical. Typical pattern, atypical pattern. Now, the atypical pigmented network is variability in the color, the thickness, and spacing of the lines of the network. And this is seen in melanomas as well as atypical nevi. Here we have examples of melanomas with atypical network. You can see that the network is thickened and prominent at the periphery. You can see there's variations in the color as well. More examples of melanomas showing you atypical network. There's another term which is called a broadened network, and it's widening of the network lines. This too can be seen in melanoma as well as atypical melanocytic nevi. And here you can see this widened network with this melanoma. A negative pigmented network is probably the toughest term to understand. The descriptive is more emphasized, where we have what's called a reticular hypopigmented lines around brown round structures. This can be seen in melanomas and atypical nevi, in Spitz nevi, and when symmetrical, a congenital nevus. And the pattern is consisting of a pigmented network. The light areas represent the grid, and the dark areas represent the holes. And here we see what's been called a negative pigmented network. And the reason why we have this negative pigmented network is that these dark structures over here are the nests of melanocytes. And when they're large and discohesive, they push the retate to the side. So it gives you what's called a pattern, which is characteristic of melanoma. Here are two more examples of this negative pigmented network. Atypical melanocytic nevi often have this type of pattern as well. And when we see this with an atypical melanocytic nevus, it's indistinguishable from melanoma and is a biopsy diagnosis. A Spitz nevus can have this negative pigmented network. And finally, a negative pigmented network can be seen with a congenital nevus. But with the congenital nevus, the negative pigmented network is symmetrical in its pattern. Crystalline structures, also known as shiny white structures, these are short, discrete white lines oriented parallel and orthogonal to each other and visible only under polarized dermoscopy, and it's seen in melanoma as well as Spitz nevi. It's rare to see these shiny white structures in a nevus. Less than 1% of nevi will show these shiny white structures. So if you have a melanocytic lesion and you have shiny white structures, you have to think melanoma. In fact, when you see shiny white structures, it's more commonly seen in superficial invasive melanomas. So here we have this melanoma in the non-polarized mode. If we press the button on the side of the dermoscopy device, now we see the shiny white structures. And this tells us that this is a melanoma, which is most likely within the dermis as well. Non-polarized and polarized. And this shiny white structure is actually due to altered collagen. And what's been demonstrated is that neoplasms with increased amount of collagen will often reveal these shiny white structures. And here are two examples of melanomas with these shiny white structures in the polarized mode. We don't see these shiny white structures in the contact non-polarized mode. A Spitz nevus can have these shiny white lines. Another term is called angulated lines, polygons, or zigzag pattern. And these angulated or polygonal lines are gray-brown lines that are connected at an angle or coalesce to form polygons, and they're often seen in melanomas on sun-damaged skin. Here we have two examples showing you these angulated lines. Sometimes these angulated lines form polygons. This is very characteristic, again, of melanomas on sun-damaged skin. Not all melanomas are the same. Again, another example showing you these angulated lines forming polygons. Radial streaming or streaks. These are radial segmental lines or radial lines. They're radial linear extensions at the lesion edge. They can be seen in melanoma, recurrent nevi, as well as reed nevi. So here we have these streaming at the periphery, and this is characteristic of a reed or Spitz nevus. Is a distinct pattern which we call the starburst pattern. Here we see a melanoma with these radial streaming, but unlike the Spitz nevus, which you had symmetrical radial streaming, with the melanoma, it's focal. And here we see the histology. A recurrent nevus as well can have radial streaming. And if you note, the area that is hypopigmented surrounding the pigment is the scar, and this is what's called a recurrent nevus because the pigment has come back. We have what are called pseudopods, the starburst pattern or pseudopods. They're bulbous and often kink projections at the lesion edge, directly associated with a network or solid tumor border. The peripheral pseudopods or streaks are located around the entire periphery with a spitz nevus. So here we see these pseudopods symmetrical at the periphery. Anytime you see symmetry of pattern, it's more suggestive of a benign lesion. This has been called the starburst pattern. More examples of the starburst pattern. Then we have what are called clods. These are round structures. They're symmetric, well-demarcated, round to oval structures greater than 0.1 millimeter. I prefer the term globules. And these globules can be black, brown, blue, white, and red. And globules actually represent nests of melanocytes in the papillary dermis. So we see these round structures, these globules. These are melanocytes at the dermal epidermal junction and the papillary dermis. And when we see these, it's very, very characteristic of congenital nevi. So here we have this pattern. It's been called a cobblestone pattern as well. For example, showing you the cobblestone pattern, you can see on the left-hand side that the round structures are pretty symmetric, as well as their very minimal variability in their color, size, and shape, as opposed to the melanoma, where you have variability in the color, size, and shape. You can see some are large, some are small, and that represents a melanoma. Globules can be black. It's very rare, and we see these with spitz nevi and melanomas. They can be blue, and we can see blue globules as characteristic of congenital nevi. And they can be occasionally white with an unusual type of nevus, which is called a balloon cell nevus. Red is not nests of melanocytes. It's actually due to neovascularization, neoangiogenesis. It's usually associated with malignant tumors. It's often a poor prognostic sign. And then you have peripheral globules. Globules distributed at the periphery of the lesion. These are seen in growing nevi. And in kids, very often, in children and teenagers, there have these type of moles which are growing. And you'll see dermoscopically this type of pattern. We know this is a growing nevus based on the fact that you have these peripheral globules. These are all both growing nevi. Two important points is that streaks, the radial streaming or radial lines, are connected to the tumor body. In contrast, the peripheral globules have spaces between the tumor and the globule itself. Both represent the same process, the horizontal growth of the neoplasm. The cobblestone pattern. These are the polygonal globules distributed symmetrically throughout the lesion, and they're seen in congenital or congenital-like nevi. And here we have an example of congenital nevus with the so-called cobblestone pattern. If you can notice, there are numerous hairs. These are terminal hairs, and surrounding the hairs are areas of white. You have perifollicular hypopigmentation, and these are all characteristic features of a congenital nevus. Milky red globules. These are seen in melanoma. And here we see these milky red globules, which is characteristic of a rapidly growing melanoma or a shades of pink melanoma. Still another example showing you this milky white appearance. We have dots. These are small round structures with a diameter less than 0.1 millimeter. They too can be black, brown, gray, or blue-gray, and they're seen with various types of diagnoses. So here we can see black in the center, and histologically is actually due to melanin way high up in the epidermis. The color brown, when you have brown dots, is due to pigment in the lower epidermis or the epidermal dermal junction. And here we have two examples. Here we see dots clustered at the center of the lesion. Also, you can see dots on the line, which are called target network. In contrast, the lesion on the right-hand side shows asymmetric distribution of dots. And when we see this, it's very, very characteristic of a melanoma. Dots clustered at the center, benign, asymmetric distribution of dots, melanoma. Peppering. This is diffuse blue-gray dots or granules on a background of hypomelanosis. And this is usually seen in the flat portion of the lesion. It represents regression, which can be seen in melanomas, particularly with melanomas, sun-damaged skin. Here we have an example of these gray dots granules or regression structures. Here we see a melanoma, and if you look in the center, you see this scar-like depigmentation, as well these gray dots granules, which is characteristic of a melanoma with regression. More examples, and you can see it's pattern recognition. All of these melanomas have the same type of pattern. So when we see these punched out areas in the center with scar-like depigmentation, gray dots granules, an atypical network at the periphery, very characteristic of melanomas on sun-damaged skin. Circles, circle within a circle. This is characteristically seen on the face, and this too is often seen in melanomas on sun-damaged skin. Here you can see these small circles, these gray circles. And here again, you can see them more prominently, these gray circles. It actually represents the melanocytes, the atypical melanocytes extending down the hair follicles. Two more examples, again, showing you these gray circles. Structureless areas. Another term for a structureless area is a blotch. When the blotch is within the center of the lesion and surrounded by network, it's characteristic of a benign lesion. And here we see the reason why you have that blotch or dark structureless area. It's due to the large concentrations of pigment throughout the epidermis, dermis, or both. And this is what a blotch looks like. The central dark structureless area with a network at the periphery. And these are often seen with individuals who have Fitzpatrick 4, 5, and 6 skin. The blotch obscures the underlying structures. Two more examples of Clark-Nevi or benign lesions, where you have this reticular homogeneous pattern with the central dark structureless area with the network at the periphery. Now you can have an off-center blotch or a brown eccentric structural zone, and that's very important because when you see this, this is often seen with melanomas. It's seen with melanomas often association with a congenital nevus. So here you can see this melanoma with this blotch at the periphery, this eccentric blotch. Here we see a lesion which clinically and dermoscopically has features of a congenital nevus, and you can see the change. And when you see this change with this eccentric blotch, this is characteristic of a melanoma in association with a congenital nevus. More examples of melanomas with this eccentric blotch. All melanomas in association with congenital nevi. So you can see it's pattern recognition. And once you learn the patterns, it's easy to make the diagnosis. A blue-white veil. This is an irregularly shaped blotch of blue hue with an overlying whitish ground glass haze visible with non-polarized dermoscopy. This is seen in melanomas, particularly invasive melanomas. And it's due to the fact that the epidermis is thickened, the stratum corneum is thickened, superimposed over atypical cells will give you this blue-white hue. And here we have 4 examples of melanomas with the blue-white veil. It's a distinct pattern. This pattern we see in the contact non-polarized mode. In the polarized mode, you won't see a blue-white veil. Instead, you'll see the white shiny structures, the crystalline structures. And again, it's due to the fact that you have a thickened epidermis superimposed over these atypical cells. Milky red area. This is a milky white appearance consisting of a red vascular blush with no specific distinguishing vessels. And here are 3 subtle melanomas. They tend to be what we call shades of pink melanoma with this milky white area. Sometimes at the periphery, you'll see a brown structureless area, which is a clue to the diagnosis. Hopefully, by the end of this program, you'll have the ability to identify and describe the subsurface structures and features of the neoplasm. Subsurface morphology and clinical morphology will enable you to arrive at a diagnosis. Now, here are some references for you. Dermoscopy, a guide for the physician, Atlas of Dermoscopy. If you go to the International Dermoscopy Society site, there's an encyclopedia of dermoscopy called Dermatoscopedia. There's teledermatology in rural Georgia. Our site actually has many of these lectures already. So if you want to review these, you can review these on our teledermatology site. Thank you.
Thank you, Dr. Ravenowitz. What a great review of so many things that are tied to what seems like an overwhelming number of ways to describe things. But as I listen to it, what I hear is that we use a lot of common language, common descriptions, which should help us all to learn to be more comfortable as we look at these lesions and we try to describe them and categorize them. So thanks for doing that in such a great way. We're going to move into our case presentation. Well, actually, we do have a couple minutes, I think, for questions. Are there any questions in the chat, or does one of the participants have a question for Dr. Ravenowitz right now? See any hands going up? Not right now. Okay, good. I see some faces, which is good, but I don't see any hands. So I've got at least one question, but I'm gonna hold it until after the case presentations because it may get addressed there. Now we have our case presentations who are going to be presented to us by Dr. Etsu Ajebo, and she's got 2 for us. Each one will last approximately 10 minutes, and then we'll have some time for discussion. So, Dr. Ajebo, please proceed.
Thank you. It's a pleasure to be here. So this patient, we recently saw him in our clinic. He was seen by Dr. Potter. He's a 59-year-old Caucasian male with a past medical history of skin cancer of unknown type, and it was removed from his left postauricular ear 1 year ago. He has extensive sun exposure history. So he came in with a complaint of a lesion on his lower back. He said it has been there for several months. So this was his clinical picture. So this was the dermoscopy picture. So should we biopsy this lesion? And so what are some of the dermoscopy findings you see here?
Can anyone provide a suggestion?
I'll go. So it looks like an atypical pigment network. You also see what looks like vessels as dots or perhaps linear irregular vessels. You also see some gray dots granules, which would indicate possible regression structures. So I think, possibly some white shiny lines toward the bottom there. So I think given the way it looked clinically and then with the dermoscopy features, you would probably want to make sure this wasn't a melanoma or possibly melanoma in situ.
Excellent, absolutely. We can advance to the next. So you can see milky red areas, shiny white structures. On the lower part, you can see structureless area, brown structureless area at the periphery. And you can see scar-like depigmentation up here and gray dot granules and atypical networking on the top side.
So one other important clue for this case, if you just go back to one slide, is it's a beautiful case showing all the structures that we spoke about. The gray dots granules, the atypical network, the milky red area, the scar-like depigmentation, the shiny white structures. And when you see the shiny white structures, that's a clue that this probably is an invasive melanoma. So just that one feature alone, it's very, very rare to have these shiny white structures in a melanoma in situ. So based on that and based on the clinical appearance, one must consider this probably be a melanoma which has an invasive component.
Wonderful. Thank you. So as Dr. Rabinowitz taught us, there are many melanoma-specific structures. So you can see them listed here: atypical networking, irregular streaks, negative network, chrysalis, crystalline structures or white shiny structures, atypical dots and globules, irregular blotch, you could see blue-white veil, regression structures, atypical bezels, peripheral brown structureless areas, and variegation of colors. So once we have identified a concerning lesion, the next step is how should we biopsy it? So there are two major ways. One is incisional biopsy, where you will remove part of the lesion. But the problem with that is if you remove the thinner section, but you didn't get the thicker part, you may miss, diagnosing, the depths of the lesion. So it may inaccurately stage your cutaneous melanoma, and it could negatively affect your treatment planning. The best way to do it is by excisional biopsy. So you can do that using 1 to 3 millimeter peripheral margin. So with excisional biopsies, there are 3 techniques you can use: elliptical excision, punch excision is the other one, and then the third one is deep shave or saucerization. So most of the dermatologists, they like to use deep shave or saucerization. It's easier and quicker. So if you look at the picture, and if you do just the superficial shave, you would miss the depths. So you would always want to go under the lesion. You do a deep shave, and that way you can remove the lesion and you can find out the depths of the tumor. So in our patient case, we did a deep shave biopsy. And his pathology report came back as invasive melanoma with Breslow depths of 0.9 millimeter. Next. And this was a special stain with SOC stain. It came back as positive. So he was diagnosed with invasive melanoma. So, once we know that it's invasive melanoma and it's a thickness of 0.9 millimeters, the next question is, what millimeter margin should we take when we are excising it out? According to American Academy of Dermatology, if you have in situ melanoma, your surgical margins should be between 0.5 to 1 centimeter. If your melanoma's thickness is less or equal to 1 millimeter, then your surgical margin should be 1 centimeter. And that if the tumor thickness is between 1 to 2 millimeter, then your surgical margin should be between 1 to 2 centimeter. And if the thickness is above 2 millimeter, your surgical margin should be 2 centimeter. Any thickness above 2 millimeter, it should always be 2 centimeter because it wouldn't have a beneficial effect for the patient taking more margins. Next. So our patient's tumor thickness is 0.9 millimeter, we said. So should he have sentinel lymph node biopsy done is the question. And what is the significance of it? So sentinel lymph node biopsy, whether it's positive or negative, is one of the most important prognostic factor for recurrence and the most powerful predictor of survival in patients with cutaneous melanoma. So according to AAD guideline, for patients who have melanoma in situ or for most T1A cutaneous melanoma, that is tumor thickness less than 0.8 millimeter without ulceration, AAD does not recommend doing sentinel lymph node biopsy. But if you have a patient whose tumor is between 0.8 millimeter thickness to 1 millimeter thickness, that means T1B melanomas, then sentinel lymph node biopsy is suggested. So you should discuss sentinel lymph node biopsy with the patient. If your patient has T2A and above, that is tumor thickness above 1 millimeter, then definitely highly recommend sentinel lymph node biopsy. The only exception here is for patients, we have T1A cutaneous melanoma and with less than 0.8 millimeter with high risk features. Those high risk features being young age, presence of lymphovascular invasion, positive deep biopsy margins, or high mitotic index, or a combination of these findings, then you should discuss with patient about sentinel lymph node biopsy. Next. So this is, these are different groups, including National Comprehensive Cancer Network and American Society of Clinical Oncology and Society of Surgical Oncology, including AAD. They all agree performing sentinel lymph node biopsy if the tumor thickness is above 1 millimeter, and to do discussion with the patient if the tumor thickness is between 0.8 to 1 millimeter. And then if it is less than 8 millimeter tumor thickness and there are no high risk features, then you don't have to do sentinel lymph node biopsy. Next. So in our patient case, referral was placed for surgical oncology, and they are planning to do excision with 1 centimeter margin and sentinel lymph node biopsy at the same time. So this is the second case.
Let's hold for just a second and see if there are any questions or comments from any of the participants.
Now, I would just say that the scoop technique is important because you need to get underneath that. So if you transect that lesion, then you've lost your Breslow level and then there's confusion. And so that's why it's so important to not just do a shave, but to really, scoop like an ice cream scoop. You want to make sure you get underneath that. And so there is a certain art to having a sense of how deep to go. So that's why sometimes if the lesion is 4 millimeters or 5 millimeters, someone might do a 6 millimeter punch around that or 8 millimeter punch, because then you don't worry about transecting it. So you can see all of this is so important because the depth, the Breslow level is the most important thing prognostically and with this next step.
Absolutely.
So a question for the participants then, just briefly, would someone care to share with us what types of biopsies you're comfortable performing, or do you normally perform in your clinic? Do you have a, when skin lesions come in? Don't be shy. This is how we learn from each other. Anyone? Okay, well, I'll just tell you that in my practice as a rural general surgeon, I was not familiar with the term scoop biopsy. 100 years ago when I was in training, we were taught to do shaves and punch biopsies. Of course, punch biopsies, you heard Dr. Davis talk about, are pretty simple and easy to perform, as long as in the circumstances we're dealing with here when we're dealing with pigmented lesions, if you can get the whole thing inside the punch, then that's good. And of course, making sure you go deep enough to lift it up and get all the way underneath it. The saucerization sounds like all I could think of was an ice cream scoop. And I'm not sure that I would know exactly what my limits are on how to do that without someone maybe giving us some details. So maybe that's something we can talk about in a future session, just a little bit in terms of techniques for biopsies. So, okay. One last shot from the participants. Anybody got anything to say or add to that?
Have a
Okay.
comment, Mackenzie Maloney. Rose, I have heard of decision fatigue melanoma. I find that is helpful tool in determining people's risk for invasive melanoma.
It's a great question. Thank you, Mackenzie. Was one of our panelists or dermatology experts care to respond to that if they're familiar with it?
Could you
Anyway, it's
repeat the
his triangle.
question?
It's in the chat. It's from Mackenzie, and she asked about Decision DX
Here.
melanoma. Do you find it to be a helpful tool
Yes.
in determining people's risk for invasive melanoma?
So the decision diagnosis melanoma is a test which is actually on the pathology tissue. And it's a genetic test, and it actually allows you to decide whether or not the patient has a potential for metastasis. That is, it classifies into levels, class 1 and 2. Class 1 is a low risk for metastasis. Class 2 is a high risk for metastasis. And it is useful for individuals where it's a gray zone area whether or not you want to do a sentinel node. It is controversial though. That is, it's not felt by the oncologist and some of the dermatologists that there's not enough data to say that it should be used as a diagnostic tool. So this is one of those controversial areas. Interestingly, the company now has a test to distinguish atypical nevi from melanoma. That is one of the difficulties for pathologists is to say, is this just an atypical mole or a melanoma? And this is another test which they are currently using as well. And finally, they have a test now for squamous cell carcinoma in terms of risk for metastasis. So it's something to be aware of. I use it occasionally in individuals who want the test ordered after explaining them, but it is controversial.
Thank you. Another information, another source of information that I was unaware with. So thank you, Mackenzie, for asking that question. Dr. Jabo, you want to go ahead and proceed with your second case?
Sure. So the same patient in the same visit, he had this lesion on his upper back for a known duration time. So this was the clinical picture. Next. And this is a dermoscopy picture. So what are some of the dermoscopy findings you see, and should we biopsy this lesion?
Let's pause for just a second, and participants, open your mics and just call out some of the things that you see there. Some of the structures, colorations, and things like that. I'm not going to call anybody out by name, but Sam Whaling, you might be very close to getting called out by name here. So.
Can you hear me? 1 second. Let me try this again.
Yeah.
Yes, we can.
1
We
second.
can hear you.
You can hear me? Okay,
Yeah.
great.
It's not a test, just what you see.
Yeah, there's, this is probably not the dermoscopic verbiage, but perhaps there's some, in the upper, I guess, picture, there's some vascular linear structures, but in the lower pole of the picture, there's, I'm not even going to use it. I'm going to stop right there.
Yeah. I think you're talking down around 6 to 7 o'clock. You're looking at some of that networking. I think that was
Yes.
what you were learning earlier. Yeah. So,
Okay.
yeah. Is it regular or irregular?
I would say irregular.
Yeah. Okay. Someone else? What else do you see?
Agree. It looks like some atypical dots, granules kind of at the periphery there. Some pink, white areas. Maybe some like fingerprinting in the periphery, which can sometimes be seen with a lentigo-like pattern.
Mhm.
But overall, I think asymmetric with the atypical pigment network and gray dots granules is concerning.
Yeah. So again,
Excellent.
lots of colors and ways of describing just the physical characteristics, kind of using common language. So I think it always surprises me when we try and make something harder than it really is. So, okay, Dr. Jabo, you want to continue?
Thank you. So as Dr. Buchanan said, you can see gray dot granules and also atypical networking. And on the upper left side, you do see fine lines, slightly curved, and then on upper right side, brown interrupted lines. So those two, the fine lines, slightly curved, and the brown interrupted lines are features of solar lentigo. But on the lower side, the gray dot granules in the atypical network, those two are features of melanoma. So again, as Dr. Rabinowitz taught us, and we've seen this earlier too, if you see, when you see a pigmented lesion and you see any of these melanoma specific structures, it would be great if you biopsy the lesion. So you may see atypical network, the one we just saw. You could see atypical dots and globules, and the rest of the findings as well. So we did deep shave biopsy in this case. And it came back as melanoma in situ. And the special stain with SOC stain was positive. So he was diagnosed with melanoma in situ, and the plan is to excise the tumor with 0.5 centimeter margin. And there is no need to do sentinel lymph node biopsy here because it's in situ. Next. So in summary, we learned about different melanoma specific structures and the different biopsy techniques, as well as management, including when to do sentinel lymph node biopsy and what surgical margin to take. Thank you.
Thank you, Dr. Jabo. That's great. We're getting a little close on time, but we still have a couple of minutes. Would love to have any of the participants raise a question or share an observation or anything you'd care to comment on.
I would just say that this man has extensive sun damage, so he's not done. You know, he has a dermatologist who's done this for a long time. You look at him when he takes his shirt off and you think, oh my, you know, so you wouldn't expect him to just have one melanoma. That second one you'd be searching for, he's at increased risk for more. And he's someone you want to get in a gown and tell him to undress and look all over because he just kind of looks like a time bomb. He's got so much dyspigmentation. The first one, you know, stands out, you know, as the ugly duckling, as we use that term in dermatology. I mean, it's just not supposed to be there. And this next one is more subtle. But anyway, he's going to need close follow-up.
Question for the providers. Raise your hand if you have patients in your practice that come back multiple times with multiple skin lesions because of similar exposures that Dr. Davis described. Oh, come on, you can raise. There's one. There you go. Good. Good. Yes, I think that's something that all of us who've been in practice and dealing with skin lesions for any length of time will have those patients that come back repeatedly with similar kinds of skin lesion presentations. I want to make sure we stay close on time here, but any other questions? I'm looking at the chat. I don't see anything else in the chat, but anything else from any of the providers? I do have that one last question that I've been holding in my hip pocket, but I'd be glad to defer if one of the participants has a question.
Oh, go ahead, Doug.
All right. Well, I will ask this time because you know, the specimens that we looked at today, the two case presentations, obviously it was the same patient, so it was the same kind of skin tone. Maybe just in the shortest possible answer, because this is probably one for an entire session, but what about dealing with patients that have darker colored skin? Talk just briefly about the challenges of that. And I may call on Dr. Buchanan for that one, just out of, just for fun.
Hey, it's definitely important to emphasize that. We see patients of all Fitzpatrick skin types, and we do know that patients with skin of color, so usually Fitzpatrick's 4, 5, and 6, they can also have skin cancers, specifically melanoma in areas that, often are, hidden from the sun, such as the nails, the feet, things like that. And under dermoscopy, things look different. And I think it's very challenging to diagnose melanoma in skin of color, especially in the early stages, which is often why it goes underdiagnosed. We know that the pigment networks look a little bit different. They may be darker, sort of more homogeneous. So it can be difficult to pick up on maybe some abnormal vascular structures and things like that. But I know, through Dr. Rabinovitz's training, we do have lectures, more to come, I would say, in the sort of darker skin types and things that, we can look out for to sort of help us make these diagnoses.
That's great. And I do think it's safe to say that the use of dermoscopy is a significant aid to the primary care provider who's trying to deal with that. So more to come on that in the future. I promise it's one of our key areas of interest, especially as we think about the patient populations that are served across rural Georgia. So we're going to wrap it up with that. And thank you for the presentations and Dr. Rabinovitz again for the excellent thing. I do think if we think about a key question today, for me, if the key question was, did this help me learn to identify and describe the characteristics of skin lesions that may or may not be melanomas? I think we covered that very well through both the didactic session and the case presentations. So with that, I'm going to turn it back over. Let's see, to Rhea.
Okay, well, thank you, Dr. Patton, for leading us through the presentations. Thank you to Dr. Rabinovitz and Dr. Jabo, and to all our participants who offered comments or asked questions. For those people wanting CME or CNE credit, Kenza will put the code into the chat. Register for your credit as soon as possible. And if you have any questions, feel free to email Kenza. Moving forward, we're going to need more volunteers to present cases from the clinics. So let us know if you have something you'd like to present. And so we're going to be asking you to fill out surveys, a survey after the session. And I'm not sure when that's going to be, but, and we need the survey information to improve the program. But in the meantime, if you have any suggestions for how to make these better, or if you have any topics that you would particularly like to hear about, please, again, let us know. You can contact us at teledermatology@augusta.edu. Our next session will be on June 6th, Monday at 4 p.m. Dr. Buchanan will be speaking on two-step dermoscopy algorithm, and we will have a case presentation by Dr. Sam Whaling, one of our healthcare providers, and the second case may be presented by Dr. Jabo, or it might be presented by someone else. So stay tuned, we will let you know. And I think that's about it. Thank you for everyone being here. I'm so pleased with the number of participants we had today, and hope they'll just increase. Remember, you can tell your colleagues about this, and we would medical students who attended, we'd love to have more medical students attending. So put the word out. Just remind our TeleDerm hub people to stay on for a few minutes afterwards for a debriefing session. And with that, I'm ready to again thank everyone for being here, and spoke participants, and can sign off now, and our team will meet briefly. So thank you very much. Have a good week.
Thank you.
shot. Okay, I'm going to stop recording.